And the nurses also have to, the nurses have to be critical care trained nurses, and also have undergone sedation training and ACLS certification. I was just wondering, I looked around in this, another excellent book. I'm sorry, I don't have the usual references at the end, but some of these books I'm talking about, like this one by Gustav and Carlos, Ketamine for Treatment, Neurobiology and Applications, and another is a really excellent one. For those of you who are interested, the books I'm talking about, you can easily get them on Amazon. They are really great if you need more information. So there's an APA consensus that Gustav and Carlos quote, and it says doctors who deliver ketamine should be prepared to deal both with clinical and psychiatric emergencies. They should be familiar with procedures to manage potential cardiorespiratory events and should have a CLS certification. That's the APA consensus about the doctors who handle, and maybe nurse practitioners. In the US, nurse practitioners also do it. Maybe just some background. So remember I started ketamine infusions in 2019. And we are still going on. This year, Dr. Catherine has joined me, and soon Dr. Sarah Gori will also be joining. So there'll be 3 of us who are doing this, and the numbers will go up. 2019, I got curious just to know how many sessions and patients have done. I was disappointed to realize that the number of patients are only 230. I thought there were over 500. The sessions that are over 500. The recommended sessions per patient, each patient can have in a 2 to 3 week period is around 6 sessions. But most of these patients, maybe some of them could get 2, others 3, financial constraints. And others maybe freak out and stop because of adverse effects, etc. Most of them, the financial constraints with the insurance, they're saying a patient has cleared, they have reached the cap for mental health. And in 2019, I had, you can see only 9 patients, 14 sessions. 2020, the numbers went up kidogo, 88 sessions, 32 patients. 2021, 98 patients. That's what there was. I don't know, the numbers went up despite COVID with 229 sessions. I must say from 2019 to 2021, it was mainly the infusions, the IV infusions. Then 2022, there are 56 patients with 221 sessions. And then this year so far, we've had 35 patients with 101 sessions. So a total of 653 sessions, which is a mixture of IV and intramuscular. We'll look at each of these. And then a total of 230 patients so far. The indications for ketamine is not only treatment-resistant depression. Of course, in Aga Khan, most of the patients who have received ketamine, either as infusion or injection treatment, have been with depression, either treatment-resistant or severe depression is suicidality. But I've also had patients with severe anxiety. I remember a patient from Mombasa who came with extreme severe anxiety, general anxiety. He could ruminate ruminations throughout all through with some secondary depression, but the mere presentation was anxiety. He went through infusions? Yes, infusions, up to 6, and said he felt no difference. Then they went to Mombasa. As soon as they reached Mombasa, he was a different person. He had improved. And he was he was in his early 70s. So I've had one case with severe anxiety and several others. Depression is always at one end, affective anxiety and affective disorders. One end is pure depression, the other end, anxiety, and sometimes it's a mixed picture. And ketamine, we found it useful for both, for those patients who respond. Supposedly OCD, it can work. I've not had any patient with OCD. PTSD, it can work. I've had one that I can remember is a patient who had had severe sexual trauma in the context of her work as an adult by her supervisor, actually in a government hospital. No, a government, sorry, not hospital, government department. The boss used to lock her and actually just rape her until she had to leave. During ketamine, what would happen would be visual hallucinations of the assailant. And she would be so agitated that I would have to sedate her to finish the treatment. So she could hardly talk about it during ketamine. But the unfortunate thing that even engaging therapists outside was very hard for her. She didn't want the psychologists in the hospital or even outside. And it was a sad case. By the time we were treating her, she was working in a bank, but eventually she had to leave because of the severity. It was not just PTSD. She also had pseudo seizures. Of course, she had secondary depression, and she had chronic back pain, etc. Substance use disorders, yes, ketamine. I have a few people I can remember. It actually can reduce craving. I have a young man who actually presented with the alcohol withdrawal seizures, gave him ketamine, but not just ketamine alone. He had also to go to naltrexone after the ketamine. And that seemed to help. Naltrexone seemed to help, but not so much. He came back again, and after 3 more sessions of ketamine injection, he's actually doing very, very well. He's completely abstinent for the last 4 months, and I hope that will continue. I saw him about 3 days ago, and he was doing very well. Eating disorders, there are various case reports, and then migraine headache. I remember a lady who was doing her PhD, came with major severe depression, actual suicidal ideation. She could hardly concentrate. Got 3 sessions of IM ketamine. And by the end of the 3rd session, she was back to her usual self. And she was migraine-free for about 2 months. It came back again, and she's now on pregabalin, but she's doing very well. So these are some of the indications. Ketamine has been reported to be useful in a lot of physical conditions, including neurodegenerative disorders like Parkinson's disease, dementias, etc. Of course, chronic pain by anesthesiologists, it has been used. This is an indication that has been there for a long time. A little bit about mechanisms of action for ketamine, just to give us, that's the basis for the protocol that we look at. It's an antagonist on NMDA receptors in the brain. And these NMDA receptors are on GABA interneurons, which are inhibitory to glutamate receptors in the prefrontal cortex. So ketamine blocks the NMDA receptor on GABA, and this results in some disinhibition, downstream disinhibition of the glutamate receptors in the prefrontal cortex, resulting in a flooding of the brain, of the prefrontal cortex with glutamate, which is also, some people have called it a glutamate burst. Just in parentheses, I've indicated here that this glutamate burst can be inhibited by the benzos. Anything, remember, benzodiazepines would increase the GABAergic tone, and therefore can easily dampen the effect of ketamine in this sense. The Z drugs like zolpidem can also do that. And lamotrigine is a glutamate. It inhibits glutamate release. And therefore, if you're thinking of giving ketamine, these are some of the drugs you need to do a washout. Benzos, it's recommended for benzos at least 12 hours. They can skip the night before the ketamine. That's what I usually do. Stop the benzo the night before. It becomes tricky if they've been on these benzos for long, so they could easily go into withdrawal. And then the Z drugs, and lamotrigine is much easier. The glutamate burst causes an increase of brain-derived neurotrophic factor. This has been described as the brain fertilizer in some circles because it causes neuronal dendritic growth, increases connections between the various brain cells, which has also been termed as neuronal plasticity. Neuronal plasticity is those structural changes that occurs in neurons. It can be an increase or decrease depending on based either internal or external factors. External factors could be stress, like chronic stress can cause these changes to occur in some of the, like the hippocampus, in cells there have been known to reduce the dendrites there, the numbers go down, the size also goes, hippocampal atrophy occurs in conditions like depression, etc. The BDNF causes the reverse, also promotes that neuronal plasticity in a positive manner. And actually, one way that is ketamine work, that the antidepressant effect of ketamine is supposed to result from this neuronal plasticity. The glutamate burst also acts on opioid receptors, the mu, kappa, and sigma receptors. And this is the analgesic activity of ketamine, of course, can also be explained by this. But apart from that, it's thought actually part of its antidepressant effect is through this mechanism also. It has been, studies have shown that if you give naltrexone, which antagonizes opioid receptors, it's an opioid antagonist, the antidepressant effect of ketamine reduces or is abolished. Then apart from that, ketamine also is an agonist. Dopamine and serotonin receptors also increases the norepinephrine tone in the brain. So it acts as a pharmacological, you can call it a pharmacologically dirty drug. It acts on everything, almost every receptor in the brain. It's no wonder its effect. It also acts on cholinergic, antagonists at cholinergic receptors in the brain. And some of the side effects we'll see, I think, are because of this antagonism. But also there's an antidepressant effect of ketamine resulting from its antagonist of nicotinic cholinergic receptors. Again, okay, now this is Dr. Stephen Hyde, the Australian, who I first heard that he was doing some research. He wrote a book, another nice book, this one, Ketamine for Depression. And this is part of his, I'm quoting him. In summary, we can view a depressive illness as a disease of disconnection at a personal, social level, and even more profoundly at the cellular level. Ketamine, through its actions on the glutamate system, induces changes in both the quality and quantity of connections between neurons. And this in turn improves the function of critical brain circuits impaired by depression, thus freeing people to deal with their problems more effectively. This just reminds me about, I think it's about 1.5 months ago, I had a 20-year-old young adult woman, a first-year student in one of our universities here in Nairobi, psychology student. While she was in high school, when she was in Form 4, she was admitted in Aga Khan with a conversion disorder, weakness. I think it was on the left side then, left-sided weakness. physiotherapy, and I think a dose or two of ketamine got her well. She went home. This time she came with the pain, right-sided pain, the upper and lower limbs, and headache, and what else? Tingling sensations on the right upper limb and leg. And she could hardly walk. She needed support throughout. The mother had to be with her to take her. She needed support to go to the bathroom, etc., etc. Of course, she started physiotherapy again, and I decided I should give her ketamine again. But she took a bit longer, much longer than she. By the end of a week, she was still being supported. The mother was worried. Asked me to call the neurologist. I still felt it was a conversion disorder, and I thought there was no harm calling neuro. The neuro team saw her, saw nothing. Realized also confirmed it was a conversion problem. During the third session of ketamine, it was intramuscular ketamine. The second dose, we look at the first and second dose in a short while. She asked me, Dr. does ketamine help people to remember things that they had forgotten? I told her, yes, it can do that. What have you remembered something that you had forgotten? And she said, she said on that day that she had remembered when she was in primary that she had visited one of her classmates for a sleepover. And while there, the classmate had an older brother, actually a college-going student. And at one point, he attempted. He decided to abuse this girl, touch her inappropriately. When he was doing that, at that point, fortunately, this girl had an older brother who came up just in the nick of time and found out that that was happening. Found that happening, and he took her home, and she wiped that out of her mind. That same day, as she talked about that morning she had been helped to go to the bathroom. When she left the ketamine session and went back to the ward, she slept. When she woke up, she didn't need any assistance, went to the washroom, took a bath, and went for physiotherapy. The next day, we discharged her. So this brings in the concept of what has been described as ketamine-assisted psychotherapy, where for the patients who during ketamine can talk, that's a very good time to talk about it, especially patients with PTSD or anything else that disturbs them, any other stressors. That's the time they can talk about them. Unfortunately, not all patients can talk, as you'll see. Others, because of what we call emergency reactions, have to be sedated and they can't talk. But even if they can't talk afterwards, they can just after the session, it's much easier for them. The mind is clearer. They can talk with their therapists, their psychologists. So the concept of ketamine-assisted psychotherapy, it's a big thing in the US. We don't have it here yet, but this is something that can be done. Efficacy for ketamine is just roughly 60 to 70%. Still much better than our traditional antidepressants, which may be 40 to, if you're lucky, to 50. And remember the time it takes for the usual antidepressants. Ketamine effect, some people even after waking up in an hour and after they come out of the session, within hours they're feeling better, but usually in 24 hours, those who respond early in 24 hours, the BDNF levels have been found to be quite maximum after 24 hours. They are feeling better already. And many patients who go up to number 6 by the third session, they are already really doing well. Unfortunately, it's just 60 to 70% respond. There are people who don't respond. I've had quite a number of patients who don't. You give them and nothing happens. They finish and they go back home. I just had a patient, high functioning patient here who went through this ketamine up to 3 sessions limited by insurance. She couldn't go up to number 6, and she didn't respond at all. Unfortunately, there are financial constraints, and she's still battling. So initially, the ketamine was given as an infusion, and that infusion is the major mode of administration even today. If you get one session, it's thought a patient may be depression-free for roughly 10 to 12 days. Some people say just roughly a week or less than a week. 2 sessions, 3 weeks, 4 sessions, 6 weeks, 6 sessions, 12 weeks. From my experience, I don't know, I think it's a bit of most of my patients, those who go up to 6, I've had people go up to 6 and actually they become depression-free. But I feel a good number of them is only up to 8 weeks. I've had very few reach the 12 weeks. But yeah, so this is from Robert Nabiswa. He goes there, he likes, and this is another book, KIST, the Ketamine Intramuscular Step System for Depression. It can really give you, if you're interested. The intramuscular method is, I'm liking it. I started the infusion, but now I've moved to intramuscular. I feel it is safe, and this guy gives the reason, this Dr. Hemstra gives the reasons for why the IM is good. It's a nice book to get from Amazon. A bit of more pharmacology. Ketamine, as we know, is a mixture, a racemic mixture of S-ketamine and R-ketamine. S-ketamine was approved in 2019, intranasal, just great anesthetic, analgesic, and sedative properties compared to R-ketamine, which is there. However, R-ketamine has greater and longer-lasting rapid antidepressant effects in animal models of depression. When S-ketamine was approved, at that time, it was thought that the R-ketamine was not important in the antidepressant effect of racemic ketamine. But this animal model showed that R-ketamine does work, and that 2021 review analysis of 24 randomized controlled trials showed that racemic ketamine was more effective than Spravato. So it's like the tables have actually turned. You know, the Spravato was, I think it was by Janssen Pharmaceuticals. It's extremely expensive. But this is our usual racemic ketamine, the usual injection. If it seems better, then it's really great because it's cheaper. A little bit about pharmacokinetics. They're important as we look later in terms of the various ketamine preparations. So the bioavailability varies from the IV, of course, is 100%. The IM is 93%. Intranasal, like Spravato, 50%. In the US, they have sublingual or troches, sublingual ketamine, troches that they just put in the mouth and they absorb 30% bioavailability. And then ketamine, I think it's the racemic mixture, is 20% if somebody takes orally. As I've said before, ketamine, many places is given IV, but other routes include the IM, the lozenges, the troches, and nasal spray, and then rectal and subcutaneous. The oral and IM administration allows for a broader spectrum of dosing and may allow concurrent psychotherapy, especially ketamine-assisted psychotherapy. The pharmacokinetics will show why the oral route could be better, and even the IM. Ketamine has 2 half-lives. The alpha distribution refers to its entrance to the brain and out of it. It's about 10 to 20 minutes. You can see how short that is. So if you give, for instance, IM, 1 dose, by 30 minutes, the patient is awake, is out of the effects of the ketamine. But the elimination half-life, the half-life to be completely out of the body varies from 1.5 to 2.5 hours. It's metabolized in the liver to norketamine and hydroxynorketamine, which are both active metabolites. And metabolism by the cytochrome P450 isoenzymes, and especially cytochrome 3A4. This one, remember, is one that can be inhibited by grape juice. So what does it mean? I don't know. Just in case a patient, they shouldn't take any liquids anyway. We'll see, we will look at the protocol. And especially grape juice could increase, it could make it could multiply, it could prolong the effects of ketamine. However, it also causes an autoinduction of these isoforms. So chronic administration may require higher doses to achieve a therapeutic effect. There's never a tachyphylaxis, we'll see. In other words, the effects of ketamine don't seem to, patients don't become resistant to ketamine. So far, many trials have been done. Patients who respond keep on responding, but they may need higher doses because of this autoinduction. Liver impairment is an absolute contraindication for obvious reasons. It's metabolized in the liver. Now, let's come to adverse events. The major adverse events that are life-threatening are spasm of the glottis and hypertension, and then what have been termed as emergency reactions. Now, these side effects may occur with a more rapid administration, especially if you're using the IV route or generally higher doses, whether IV or IM. I must say our 1 year fatal incidence here in Aga Khan in June 2019, when I was just starting, a German diplomat, a woman, a female, in the HDU. I had just left the patient in HDU to go to the medical ward to check on a patient in the medical ward, and came back, 30 minutes later, found ketamine had disconnected. I was informed by the critical care medical officer was there that she had been found. The saturations had dropped, she was turning blue. They're almost intubating her. It was discontinued. And so this monitoring is very important. Close monitoring is very important. Ketamine-induced hypertension, one of the side effects of ketamine is blood pressure invariably goes up. And people who are hypertensive, it can really go up. Even people with normal blood pressure, it does go up. And the rise can be between 10 to 50%. For patients where it really goes up, and for me, what determines whether to bring it down is the mean arterial pressure. I've talked to the cardiologists and they tell me the MAP, mean arterial pressure, is very critical. It's not really the systolic or diastolic that matters. Of course, you use them to calculate the mean arterial pressure, but the MAP beyond 115 is a worry. It means you're straining the heart. Anybody with if we did, maybe we missed an ischemic heart disease and they have a MAP of above 115, chances of myocardial infarction are high, or other or increased intracranial pressure can also occur, and therefore, yes. So when the MAP is above 15, I use most of the time the literature would say clonidine, cataplasma is the best to use. Midazolam you can use, but remember it's a benzo. It can dampen the effect of ketamine. I've also had to use labetalol. Again, this year, February, I had one very difficult patient. He has had ketamine before, non-hypertensive, but that day he came and he forgot to take his antihypertensive medications. And the pressure after the first dose of ketamine IM, it went to, the systolic went to, at 10 minutes, went to 260. The diastolic was 160. The guy was crying. I just see tears streaming on his face. I don't know what was happening inside him. I gave clonidine, nothing. IV, nothing. Pressure was still up. Midazolam, pressure was still up. I had to get labetalol, 20 milligrams, slow push. That's what brought the pressure down. It was a very scary thing. When he came up, asked him what happened, he said, I forgot to take my antihypertensive medications. I was very annoyed with him. So patients with the blood pressure, you need one is to have you taken your medications. And for such patients, I prefer giving, if they're inpatients, I give clonidine, even an hour. That's the one thing I leave them to take in the morning, 2 hours before the ketamine, small sip. So it's very important that the pressure, if they're antihypertensive, make sure the pressure is well controlled. They are very extremely sensitive to the pressure going up. The IM route does not allow a rapid rise in ketamine blood levels. And why is that so? According to this Dr. Robert Hemstra was written this book, this excellent book. You deposit, when you give it as an injection, it goes into the muscle, and then it is slowed as it diffuses through the tissue before trickling into the bloodstream with a little of the shock of the concentration gradient generated by open files of an IV ketamine line, as he calls it. I mean, if the line is directly into the vein, the levels keep on just rising as time goes on. And what you call those adverse events can easily occur. What are the ketamine emergence reactions? These are what have been referred to as psychedelic. Some people have referred to ketamine as a psychedelic agent. Some of these reactions can be positive, euphoria. I've had patients who have told, I remember a patient who told me, I went to heaven, I came back. A spiritual-like experience. A patient who likes when he's on the bed, he's praying. Just some of the side effects can be negative, like panic attacks. Some patients with panic attacks drop out.
Juliana akanambia tumesikia ni kama ameenda mbinguni na akarudi.
Then some patients can have what has been discussed, a bad trip or freak out experience in the context of dissociative episodes. These dissociative episodes are almost like out-of-body experiences. I've had patients who have told me, I'm traveling, I'm in space, I'm flying. They are talking, describing what's happening to them, and I'm flying, I'm in space, I'm flying. And it can be a positive experience, but others feel like they're going through a dark hole, and the feeling is that I'm not going to come out of this thing. I'm dying. And it can be very, very unsettling for some of these patients. So these are the emergency reactions. And the higher the dose, the more likely they to occur, and especially the IV route. But even the IM, the higher the dose. Other common side effects are nausea and vomiting. And before the ketamine, we need to give an anti-nausea medication. And in Aga Khan, we use ondansetron, which is also available as the film preparation. You can take a sublingual or IV half an hour before they get the ketamine. Promethazine can also be given IV. Sometimes I give it some patients need both promethazine and ondansetron. Dizziness is a big problem is invariable, and it can occur up to 4 hours after the ketamine, and therefore false risk is a big problem. Part in the consent, the patient have to be informed that that's a risk. And I usually advise my patients not to drive and not to engage in any physical activity up to 6 hours to ketamine. Visual hallucinations of people they know, their families. Some people tell me, my grandmother, my father, my sisters are here. Others may be late, or leaving. Heightened colors, very common. Description, blurring of vision, and the anticholinergic effect of ketamine. Photophobia, phonophobia, they are very sensitive. Some people just want lights out and no noise. Tachycardia can also be a problem. And for me, when the heart rate reaches 130, it threatens to reach their clonidine comes in, or midazolam, but I prefer clonidine. Headache, paradoxically, yes, headache can occur for a few after the ketamine, although it can prevent migraine headache, but headache can occur briefly, and then it goes, paracetamol goes away, analgesics. Also, the ketamine bladder syndrome has been described as a long-term side effect, but it's common more in drug addicts, ketamine abusers. Medication, so far the many ketamines that have been given, and even for us, the 230 patients in Aga Khan have not seen this side effect. But the higher, the ketamine abusers use extremely high doses of ketamine. They're the ones who are prone to this. So what's the protocol in Aga Khan? For patient eligibility, they should be American Society of Anesthesiologists, ASA 1 category, or maybe ASA 2. Patients with moderate to severe depressive symptoms who are failed to respond to at least 2 adequate antidepressant trials, that's TRD, treatment-resistant depression. But many people are wondering, ketamine does so well, why even try somebody on antidepressants? Why not just start with ketamine? But anyway, for us, this is what we do. Then the severely depressed patients with the suicidal ideation. This is the ASA thing. ASA 1 is healthy patients. ASA 2, mild to moderate systemic disease caused by the surgical conditions or other pathological processes and medically well-controlled, like well-controlled hypertension, hypothyroidism, etc. Exclusion criteria: active psychotic symptoms, obviously, manic symptoms, it can cause a manic-like state. I've bolded a history of primary psychotic disorder, I've had patients who have had a history of a history of psychotic symptoms in the past. I've had a patient who had what appeared to be a schizoaffective disorder, significant psychotic symptoms in the past. She presented with mainly depressed. And actually had voice, the voices were there, the usual derogatory voices, you are useless, you're bad, die, etc. Gave her ketamine and the voices went. So sometimes this has to be relative. We have to judge and see. Non-hypersensitivity, ketamine, obvious, uncontrolled hypertension, obvious, in pregnancy or breastfeeding women, not indicated. Ischemic heart disease, obvious. Cardiac arrhythmias, all these are self-explanatory. Baseline investigations are important and for obvious reasons, including ECG, LFTs. The personnel, based on what we had already seen earlier, for us in Aga Khan, it has to be a psychiatrist, as we already saw, a CLS certification and sedation training. Critical care nurses is sedation training also. Consent is important, and it could be the patient himself or herself, if they have capacity. If they don't have, then a guardian or a parent or a spouse would give. And education about the benefits and potential common side effects, including nausea, which is almost invariable. It's invariable actually, drowsiness, dizziness, sensitive symptoms, hallucinations, tachycardia, and increased blood pressure. That should be mentioned. I never talk about the ketamine blood, I've never seen it. For patients under age 18, a parent or a guardian will give consent. Location in Aga Khan, most of the time is the cardiac catheterization lab, the cath lab. Here, I like a nurse takes over the ketamine patient and she will be the patient. Under the patient. In HDU, they assigned many other patients that they have to look after. And that incident I had gave me a fright. But sometimes if the patient presents in HDU with an overdose and they are on, of course, there's a critical care monitor. So I give them ketamine there too. ICU also, if they are there, as they are recovering, I can give, they can also get ketamine and CCU. The initial ketamine dose has always been 0.5 milligrams for the IV. The total dose is calculated 0.5 milligrams per kg. If you are giving as an IV, 0.5 milligrams per kg infused in 50 millimeters or normal saline over 40 minutes with the continuous monitoring. Or given IM in 2 doses, 30 minutes apart with continuous monitoring. The IM route actually allows for higher ketamine doses in a session. The monitoring is The monitoring is done by a psychiatrist or a designee that the psychiatrist chooses, and of course the critical care nurse. All patients are connected to a critical care monitor that will show the heart rate, blood pressure, respiratory rate, and oxygen saturation. The psychiatrist or his designee supervising the ketamine infusion must be readily available for the entire duration of the procedure in case of abnormalities. And unlike ECT where you can go in, zap the patient and leave, unless the anesthetist delays psychiatrist. For ketamine, one of the drawbacks actually you have to be there. You can't afford to leave the patient with the nurses alone. You have to be there. Things just keep on changing. These emergency reactions, blood pressure going up, tachycardia coming, saturation going down. You need to be there to give the guidance of what. Of course, saturation, the nurse, critical care nurse will give oxygen. But when it comes to the emergency reactions, it's the psychiatrist. You have to decide what to give to sedate the patient or what else, like the blood pressure, what to give. Post-ketamine infusion monitoring, the vital signs that we've already mentioned. Part of it is make sure the patient is easily aroused, oriented, and appropriate before discharge. Inpatients are transferred back to their ward, and daycare patients are discharged home in the company of a relative or a friend. Sometimes you get daycare patients coming from home, arrive in the morning, get the ketamine, and then for roughly ketamine is over by 10, by 12, they're ready to go home in the company of a relative. Not good for them to go alone because of the dizziness that usually is still there, and no physical activity allowed up to roughly 6 hours to the ketamine. In conclusion, is what has been called the siege cycle. The siege cycle was coined by Dutch medical historians, Snelders, Kaplan, and Peters, to describe the dynamic phases of the career of psychiatric drugs. Max Siege, a German psychiatrist, proposed the concept that tropic drugs have a cyclical livelihood. Initial enthusiasm and therapeutic optimism, subsequent negative appraisal, and finally limited use. It reminds me of the SGS. Remember when the SGS, second generation antipsychotics came in? You are old, it was a lot of enthusiasm. They don't cause extrapyramidal side effects. They're very good for negative symptoms. A few years later, the metabolic syndrome kicked in. A few years later, the CATI trial came in and we saw that maybe they're not that much better than even the first generation antipsychotics. And now there's this much enthusiasm about ketamine. Will it go through this siege cycle? Time will tell. Thank you very much for listening to me.
Thank you very much, Dr. Nabiswa, for that very good and insightful presentation. I would request that you hold your questions for just about 10 minutes as we listen to our sponsors for today. I'm already seeing hands going up, so you'll just give us a bit of time. Kindly, the representative from Microlabs, kindly could you present?
Okay, good evening, doctors.
Good evening, we can hear you.
Okay. So we are going to present today on Microlabs and our products that we do promote for this particular session. I don't know, Mr. Vipin. Okay, let me share my screen.
Felix, good evening. Good evening, all doctors, respected doctors. Can I present the slides for you, Felix?
Okay, it is okay.
Let me present for you.
Okay.
Okay,
So first of all, yeah, it is visible. First of all, we would like to appreciate Dr. Nabiswa for the wonderful presentation. And we also want to thank the KPA for incorporating microlabs in general, actually to come in partnership for this particular wonderful CME. Microlabs.
Okay, continue.
Yeah, so we find that Microlabs is a pharmaceutical company, and actually it has got multifaceted global healthcare organization. And we have got a vision as Microlabs. So to be leaders in the development, manufacture, and sales of premium pharmaceutical products, and also to make a worldwide contribution to the society and to deliver value through high quality products. So Microlabs is well known for quality products and also affordability of our products. 14 world-class manufacturing facilities. You'll find that Microlabs has got a global footprint almost everywhere. It is present in 70 countries with ground level operations, spanning Africa, Asia, USA, Europe, North and South America, and the Middle East. And 3 R&D centers, 300 scientists engaged in product and analytical development to ensure quality. So actually we have got approvals. All the particular brands that we are going to present to you, dear doctors, we have got approvals from the following regulatory bodies. So in case of any question, any product, even Syscol, which is our major brand, it has got approval of US FDA, World Health Organization, PPB Kenya, UKMHI, RFDA Rwanda, Health Canada, MCC South Africa, TGA Australia, MedSafe New Zealand. So those are all approvals worldwide, all of them. So you find that Microlabs is very well and renowned as a manufacturing company. We also do our own marketing and our own regulatory. Okay. And that one makes us apart. It sets us apart as a company.
I'll call you.
Okay, let's continue. So these are our brands of focus. Majorly for the specialties, we will focus more on Syscol, which is our citicoline 500 mg, Meconav Forte, and the Pantotab, which is our PPI, Eucerin, Uridos, and also we have got Micromox, which is our fluoroquinolones. So to start with, we have got a very powerful and fantastic brain boosting nootropic, which is actually our neuroprotective choline. Citicoline by the name Syscol 500 mg. You'll find that doctors, we actually request and on Syscol, because it is more related on line of your career. So you find that especially in repair neural membrane, it helps in repair neural membrane via increased synthesis of phosphatidylcholine, which modulates brain functions. It also reduces free fatty acid that builds up at the site of stroke-induced nerve damage. Our Syscol or citicoline, it also counteracts the deposition of beta amyloid. That is a neurotoxic protein, which is believed to play a central role in the pathophysiology. That is the formation of plaque for Alzheimer's disease. And also, okay, then we find that there is a study or an experiment. Can you go back a bit? Yeah, there is a study that was done by Brown, and this one was on cocaine. Patients who were actually the people who were taking cocaine. It was evidence when they were given citicoline 500 milligrams per day. It actually improved their control. At the same time, it also reduced the need to take the drug, the cocaine. So whereas the dosage sometimes can be given fourfold, a higher dose, it was found that it improves also the memory. So there's also reference materials for that particular study. And also people with the alcohol withdrawal syndrome who are administered 1 gram per day for 60 days. Actually, it was realized they exhibited improved concentration and time and space orientation. So we'll find that influence of citicoline on food intake was also subject of study. Its administration of 2,000 milligrams per day for 6 weeks was considerably reducing appetite, which was actually brought some functional changes in the selected brain areas responsible for appetite. At the same time, we find that there's a Ruhi et al. Experiment demonstrated that the benefits of combined therapy of citicoline in patients with major depression at a dose of 2,000 milligrams for 6 weeks, actually it brought a lot of improvement on the patients. And also Gaja et al. Concluded that.
Hello, Felix, 1 minute.
Yes.
I had given you 10 minutes and I'm seeing like you have exceeded your time. So I'm hoping
Yes,
you could wrap up in the next 2 minutes, please, so that we can go back to our discussion. Thank you.
All right. So for citicoline, you find that mostly the major indications, I'll just go very fast because of time. For this indicated for neurodegenerative disorders, as also discussed in our topic of today, and also behavioral problems, that's mostly you encounter, and also major depressive disorders. You can actually count on Syscol, our citicoline, and lastly, on the vascular cognitive impairment, our Syscol is good on that. And additionally, as is also used as a brain supplement, whereby citicoline helps to raise the level of important neurotransmitters like acetylcholine, dopamine, and even glutamate that was, as it was mentioned. It also increases mental energy and protects your brain from damage and aging. So our Syscol is the main brand that we are promoting for today. The others I will just mention, but doctors, we are also arranging for a physical CME soon, and we will talk in details about Syscol. So I just mentioned the rest as I finish over. Our next product is Meconab Forte, which has got mecobalamin, benfotiamine, and then it also has got alpha lipoic acid. So this one is very good, the tingling sensation that Dr. was mentioning, and even numbness. This is the product and the neuropathies, alcoholic neuropathies. Also, we have got Pantotab. For Pantotab, actually, this is our pantoprazole for our PPI. So this one we'll talk more about it. Then also we have got Uridos, our silodosine. This is our uroselective alpha blocker for BPH and LUTs. And also we have got our urisoren, our solifenacin. I know sometimes you people get patients with the sensitive bladder. Actually, you can consider solifenacin, that is our urisoren in that particular case. Doctors,
I think your
lastly,
time is
micro
up now.
mox.
We have been
Yeah,
very
it's up.
patient. Kindly.
I've just finalized with the micromox, which is our fluoroquinolones. We thank you so much for your time, and we ask for your support, more so Syscol and the MECONAV in that matter. Thank you so much.
Thank you. Thank you very much. So we'll proceed to the discussion for the evening. So going back to the presentation that we have been listening to, I've seen a few questions on the chat, but prior to that, I had seen 2 hands up. There was Prof. Gakinya and there was Dr. Makanyeng. Dr. Makanyengo. So, Prof. Gakinya, do you want to go first, or your hand was up by mistake?
I really didn't have a question. I was just clapping for the present. I was happy. Thank you.
Okay, all right, thank you. Dr. Makanyengo, kindly.
Thanks, Prof.
Hello.
Dr. Makanyengo, yeah, we can hear you.
You can hear me?
Yes.
Yeah. 2 questions. One is how much would the medication cost? And then the other thing is if one has to be trained, and the sedation training, what does it involve? Some of us would like to be trained. Thank you.
A part of your question was not clear.
How much do they charge? How much do the patients charge?
Okay, that's the cost of ketamine?
Yes, for the session, per session.
Okay, all right.
So that one is the cost. Ketamine itself, a bottle of 500 milligrams, which can go up to maybe 6 sessions, depending on the patient's weight. The bottle is just between maybe around 500 to 600 shillings, ketamine, the Resmic that we're using. The Spravato, like in the US, I don't know, initially it was over $1,000. I think it's come down a little bit. A spray, which was a lot of money. But anyway, we don't have it here. So the bottle here, the Resmic is about 600, let's say 600 shillings. The cost per session in Aga Khan is about 40 to 45K thousand. And I think this takes the monitoring. The causes of the cost going up is the monitoring, which is sometimes at least up to 2 hours, sometimes beyond 2 hours. The personnel, of course, involved, the nurses and the doctors. Yeah, a third of the money goes to the doctor in Aga Khan. So about so it's, you can imagine. So it's about yes, 40,000 shillings. It varies depending on whether there are complications. Are you giving the clonidine? Are you giving what? Those are the extras that can cause it to reach around 45. But the second question I didn't get.
The second question is about training. Now, if I want to be trained, who are you training us? How much? What is involved?
Have you had Dr.
Is that
Catherine?
ACLS and sedation?
Oh, the training, sedation
The
training.
sedation training, yes.
Yeah, in the past, Aga Khan was conducting a face-to-face. The year 2019, it was face-to-face. I think when COVID came in, then it went online. So there are just certain parameters that they are looking at: assessment, physical assessment of the medical assessment of the patient, the medication, the various medications that one can use in sedation. It's not just ketamine. It could be benzos, it could be ketamine itself, any sedating medication, the monitoring of the patient, why that is important, all those parameters. The face-to-face used to be a one-day course, but the online course is for, I think, Aga Khan staff, and you do it at your own pace. But you have to pass, it has to be 100% or something like that before you get the certificate.
Okay, thank you.
Okay. I'll ask a few questions that are on the chat before I take another hand. I'm seeing Dr. Jaguga's hand is up, but I can see here from, I think this is Musau, who asked, do you taper off the other antidepressants patient has been on before giving ketamine? And then I'll just combine that with Dr. Leonard Njero's question on whether there are guidelines for using ketamine in treatment of postpartum depression.
For postpartum. Tapering off antidepressants, yes and no. Depends. Is it polypharmacy? You know, especially bipolar depression, is very difficult to treat. And it's not unusual to find somebody's on moods, on maybe lithium or lamotrigine, plus some antidepressant on top of that, plus maybe aripiprazole, you know, small doses of that. So it depends. So if a patient comes with bipolar depression, for example, they are on lamotrigine. Remember, lamotrigine is it dampens, antagonizes the effect of ketamine. You'll have to stop that one. What I do, I don't stop forever. I just for the time they are getting the ketamine, I would have to stop it then as soon as the ketamine sessions are over. Some of them may have been partial responders, but if they have gone down and they've been on it for long, maybe it's the time to think, do they really need that medication? So generally and if it's acute depression, you've just started them on antidepressant, maybe they're acutely suicidal, and therefore you don't have to, it's not a reason to stop the antidepressant when you're giving ketamine. Or patients can safely get ketamine plus the antidepressant together. So it depends on which medication. The benzos, of course, are the ones that you would worry about, and the Z drugs. Then number 2, guidelines. Postpartum depression, it's not differences. It will just be hard. Or the males, okay, now I can see now, that's a bit tricky. If the mother is lactating, becomes a bit tricky there, because one of the contraindications lactating mothers. But otherwise, if they are not lactating, now you have to look at the pros and cons. Maybe if you feel the mother is in danger, they are acutely suicidal, then that's the one time the lactation will be put off and then they get the ketamine. So you'll have to weigh the two options. Otherwise, there are no special guidelines just for postpartum depression.
Okay, thank you. There's one question from Lynette Ongeri, who is asking, are the oral formulations, the lozenges, available locally, as they appear to have less side effects? And as you respond to that, maybe you could respond to one of the attendees, Eunice, who is asking about the liver functions. What do you look for, especially for patients who have alcohol use disorder? Knowing that they are usually deranged, what will determine whether a patient can get the ketamine or not?
Okay, thank you. So for lozenges, no, we don't have, unless some people, the abusers can bring them in. But otherwise, locally, we don't have them as a pharmaceutical product yet. Yet in the US, they do have them. Interestingly, the lozenges, ketamine, of course, it's oral, it metabolizes in the liver. And those products, remember hydroxyketamine, is extremely potent as an antidepressant. And it does not just work through the glutamate thing. It goes, there's also what you call the lateral habenular nucleus, just above the third ventricle. That's another site for ketamine activity. And HNK works there. So the lozenges, and they are cheap. Actually, the future for ketamine is using lozenges and oral ketamine. If you can get this. The future does not lie in the injections and the infusion. The future lies with the lozenges and the oral ketamine. If you can we have the I think in palliative care in Aga Khan, we use oral, the rest with ketamine. Somehow those patients are given for pain. But I wonder whether we can also use that for depression, is a thought. But the future lies with the lozenges and oral ketamine. And intranasal, but it's so too expensive for now. So I leave that one there. Then LFTs, the liver is deranged when, if the patient is jaundice, for instance, if they have that extreme liver, we are talking about extreme liver impairment. Just the usual increase in liver enzymes is not a contraindication for use of ketamine. That occurs with alcohol use disorder, the gamma GT, the alkaline transferase, just the usual. That alone is not a contraindication. But if they are jaundiced, especially then you worry. Or liver cirrhosis, if they already are liver cirrhosis, then you don't want to give them ketamine. But if it's just the fatty liver and raise of the usual enzymes, then you can still go ahead and give ketamine. Although that's a bit tricky, again, remember, you'll have to stop the benzos. So you'll have to detox the patient first. You don't give them during the first week. Detox the patient until the risk for alcohol withdrawal is over, then you give ketamine. Thank you.
Okay, thank you. Thank you for that. I had left out a question on the public hospitals where they're not well equipped, as you have brought out. There are quite a number of requirements while giving the ketamine. There was a question on what great indications would lead to use of ketamine in such a setup where they are ill-staffed and ill-equipped.
Yeah, I think the main problem there is the monitoring and even critical care nurses and all that. It is, ketamine is safe, but I think those are the constraints. Using in a public hospital where there is no, it has to be a place where the patient is connected to a monitor. If you're giving it parenterally, if you're giving ketamine parenterally, IM or IV, or even if you had the intranasal form here, the patient still also need monitoring. The patient has to be connected to a critical care monitor. So that's a very difficult one. The day we'll have these lozenges, because in the US, patients go home on lozenges and they're cheaper. With the day I don't know I've never understood who brings drugs into this country. Because there are times you find you are lacking medication. But if you could get some of these lozenges, they are cheaper even in the US. I wonder how much they cost here. But that's the way to go. Because they try them in the doctor's office, and if all is okay, then they are given a number to use at home daily or twice, whatever. The frequency is determined by the psychiatrist. That would be the way to go for our public health system, oral ketamine or lozenges.
Okay, so quite a number of compliments. I would say from Dr. Mutisia, excellent presentation. From Dr. Jaguga, very interesting presentation. Dr. Wafula, very insightful presentation. And thank you for the information shared.
Thank you very much.
Yeah, we'll listen to Dr. Jaguga. I can see her hand is still up.
Yes, Catherine, thank you. And thank you so much, Dr. Nabiswa, for this presentation. So 2 questions. One is how do you select patients for ketamine? Here in MTRH, we tried it with a middle-aged man with intractable alcohol use disorder. How do you select? Do you even pick patients with moderate risk use or low risk use? How do you decide who gets ketamine for alcohol use disorder? And 2, here we tried single dose, low dose, just like the one I saw you give for substance use. So my question is, do you give multiple doses? Do you give single? And how far do you go? If you look at the literature, the highest number I've seen being given is 3 doses, 1.
Your voice has gone.
Dr. Jaguga, I think you lost your connection. We can't
Yeah.
hear you very well.
So how is your dosing schedule for? Oh, really? Summarize. One is how patients are selected for ketamine, patients with alcohol use disorder. Do you pick the severely ill ones, the ones non-responding to other treatments? Or is it like a patient could show up the first time and you decide to give ketamine?
Okay.
And two, have you given ketamine more than a single dose? Have you given multiple doses? How far have you gone in terms of the number of doses for ketamine? And specifically, I'm asking about alcohol use disorder.
Thanks, Dr. for your question. Selecting patients with alcohol use disorder, many factors come in. I mean, remember, there are patients with alcohol. It has to be a patient who says, I want to stop. Right? Like the young man, after the seizure, it was a wake-up call. He had a seizure. Then I think before the seizure, he crashed his car. And then soon after, he had, of course, the CT scan had been done. There was no bleeding or anything. And then he had this withdrawal. It was clearly alcohol withdrawal seizure. And he just felt he couldn't function that way. He had to make an about his life. He chose to not to. And he was extremely serious. So motivation, they need to, you've seen alcohol, patients with alcohol use disorder. There are those who are ambivalent. There are those who are brought by family by force. That kind of patient is not a good kind. By the way, people who are actively, ketamine will not work. Alcohol, remember, is also like a benzo. So alcohol also dampens the effect of ketamine. Now, for ketamine to work, you have to detox them, number one, so the danger of withdrawal is out, and they are not actively using any alcohol, and then you start giving them the ketamine. And that's how it will help. It will then help, I think, through maybe the opioid, I don't know. Remember naltrexone? Naltrexone helps to reduce craving. I don't know, through complex mechanisms, the ketamine also comes to help. Not just alcohol, various drugs. I had a patient, a lady, sorry, now time maybe is not allowing us, abusing multiple drugs, cocaine, ecstasy, everything from LAM. Came here and told me now she had gone to started using ketamine, illicit ketamine, and then the desire for other drugs disappeared. Now she came saying, now, how do I come off this ketamine? That was the question. I told her, okay, you come, and then we see the way forward. I was thinking of actually giving an naltrexone for the ketamine addiction itself, but she never turned up. So the patient has to be motivated. In terms of doses, those who are motivated and you are giving the ketamine, I think it's best to give up to 6 sessions. I call them a session. If it's infusion, 6 infusions. If it is intramuscular injection, each session has 2 injections, half an hour apart, and at least 6. I would advise that. This young man got the 6 and is doing quite well. So I would not pick a patient who is poorly motivated, because I remember one of the inclusion criteria for ketamine, patients who are abusing substances, actively continuing to abuse, those are a bit tricky. Somebody has to say, I want to stop, and then you give them ketamine to aid them to stop. Thank you.
Thank you very much, Dr. Nabiswa. We have really learned. I'll talk on my own behalf. We have learned a lot through this very insightful webinar. And thank you for sharing all those resources. I hope they'll be of help to everyone else. My very short experience, I don't think there's much to say, but I've been so used to ECT, which is very straightforward, that I find ketamine treatment sort of like a roller coaster experience. So anyway, that's a discussion for another day. So being that we are from Aga Khan University Hospital, and I can see our dean here, I don't know if you'd want to say something before I hand over the meeting to Dr. Kwaba.
Thank you very much, Catherine. I don't have anything to add. So it was a very insightful presentation. I've enjoyed listening to Dr. Nabiswa describe what you guys are doing in the clinic. And I think we should just have more of these sessions that we share experiences and, maybe we pick one or two new things from each of them. Thank you very much. And thank you everyone who made time to attend this session. Looking forward to having many more like this. Thank you.
Okay, thank you. Dr. Kwaba, anything else to say?
Dr. Catherine, for leading us very well this evening. Thank you, Dr. Nabiswa, for a very, very stimulating talk. Thank you, everyone who made time to come and listen to us. And just to remind all of us that every last Thursday of the month, we intend to have a CME meeting. And the hope is that you can also share with us the messages that you'd like us to discuss, because this is our meeting, this is our space where we can improve our practice. Like we have learned from Dr. Nabiswa, there's so much we can do with our lives other than just prescribing oral medication and IV medication. We can go to theater and give an infusion. And I know Dr. Florence has done that in Eldoret, and it was not a small deal, it's a big deal. And I think it's a very good thing that we can share these experiences. If you are doing transcranial brain stimulation, please come and tell us. So please feel free to reach out to us so that we can organize a CME for you to tell us what you're doing in your space. And also please share with us topics you're interested in hearing more about. We really appreciate it. And as we close, just to keep reminding us, September is coming soon, and we are hoping to all meet in Kisumu for the conference. And we are hoping that you'll share your abstract in the next week. The deadline actually should be 7th of July. If you haven't sent your abstract, if you intend to share anything, please share with us the abstract so that we can review them. And also remember to pay your membership fee so that we can support KPA in its activities. We want to thank everyone, and we look forward to meeting you next month on a Thursday like this one, and we'll share with you the topic in due course. And I know we've had challenges with our CPDs that for the meetings that we've had previously, but yes, we are aware of that, and we are working to make sure that we can share. And even for this meeting, we expect that we'll be able to share the CPD points on time. Thank you very much. Have a restful night. Bye-bye.
Thank you. Thank you.
Thank you.